Hi, my name is Miriam Rafferty. I'm a physical therapist and a research scientist at the Shirley Ryan Ability Lab in Chicago, and an assistant professor in the Department of Physical Medicine and Rehabilitation at Northwestern University. What are guidelines? Guidelines are a public recommendation on exercise prescription for people with Parkinson's disease. In other words, they are objective knowledge about the frequency, intensity, time, and type, as well as the volume and progression of exercise that people with Parkinson's disease should receive. The guidelines that I am presenting today are the professional facing guidelines. They are not developed for people with Parkinson's disease to be able to read and understand and apply them independently, although community facing infographics are also available. Guidelines also are not related to the quality and skill and application of the guidelines. So, knowing the guidelines doesn't ensure competency of the exercise professional. That's what the competencies are that I'll talk about a little bit later. Here is a copy of the Parkinson's Foundation exercise recommendation for people with Parkinson's disease. On the slide I'm presenting here, it is the draft from November of 2020. And at the time of your viewing of this presentation, there may be more recent versions. These will be shared with the team training and Parkinson's participants and are also available on the Parkinson's Foundation website. Some of the things that I would like to highlight on this slide are that we have 4 exercise domains: aerobic, strength, balance, agility, and multitasking, and flexibility. One of the things that makes this guideline different from the guidelines that you have perhaps seen in the ACSM exercise guidelines is the addition of this column on balance, agility, and multitasking. The review committee and development committee really felt like it was important that we highlight this as its own domain of exercise for people with Parkinson's disease. One of the other things that is a little bit different is the disease-related considerations. So this contains some of the comorbidities and specific things that an exercise professional should think about across the 4 different domains of exercise. And finally, at the bottom of the guidelines, we recommend that exercise professionals consider collaborating with licensed physical therapists specializing in Parkinson's disease to assist with a full functional evaluation and individually tailored exercise recommendations that can take into account a complete medical history. And now I will go through each one of these sections in more details on the following slide. The exercise guidelines were adapted from many sources. First, we took existing exercise guidelines from the American College of Sports Medicine's guidelines for exercise testing and prescription, as well as the American College of Sports Medicine exercise management for persons with chronic conditions and disabilities. Both of these do have some information on Parkinson's disease that was really important for us to form a basis for our guidelines. We also found other exercise guidelines and recommendations from the National Center on Health and Physical Activity and Disability, NCPAD, and as well as the U.S. Department of Health and Human Services, who have physical activity guidelines for all Americans, including those with disabilities. The exercise guidelines were supplemented by physical therapy resources, including the physiotherapy guidelines for Parkinson's disease from Europe, as well as from a physical rehabilitation textbook for physical therapy. Parkinson's disease specific research in exercise and physical therapy was also reviewed. Some of the references that were really important in the 4 different domains will be shared with the team training participants, as well as expert opinions from physical therapy and exercise stakeholders who are a part of the exercise convening and competency development groups. For aerobic exercise, we recommend a frequency of at least 3 days a week. We recommend an intensity to begin with moderate intensity, 40 to 60% of heart rate reserve or VO2 reserve, which would be an RPE, a rate of perceived exertion of 12 to 13 out of 20 or 3 to 4 out of 10, depending on the scale that you're working with. We recommend that individuals progress to vigorous intensity or an RPE of 14 to 17 on the scale from 6 to 20 when it's physiologically appropriate and safe to do so. And we encourage exercise professionals to teach the client to self-assess. In other words, this doesn't need to be something that is supervised all the time, every single session. We do hope that people with Parkinson's are doing this more independently on their own. unless they have a health condition that warrants supervision. For time and volume, we recommend at least 30 minutes of continuous or intermittent exercise per session. By intermittent, I mean interval, walking and running. We recommend that people build to at least 150 minutes per week of at least moderate intensity exercise. The physical activity guidelines for adults in 2018 did remove that baseline, it needs to be at least 30 minutes of aerobic exercise. And I want to take a minute here to highlight the difference between physical activity and aerobic exercise. So physical activity is any activity that increases your metabolic rate above resting, whereas aerobic activity is a prolonged rhythmic activity using large muscle groups specifically with the intention to increase fitness. And I think it's important to kind of define these terms and to help as a healthcare provider, to help our patients with Parkinson's disease to understand that all physical activity is good in any duration bout that they can get, whether it's walking the dog or doing some housework in their home. But when it comes to exercise, particularly aerobic exercise, it should be done with the mindset that they are doing it for the purpose of their fitness and they are focused on that activity at that particular time. Some examples of aerobic exercise include treadmill training at moderate to vigorous intensities. Some very effective protocols have included multi-directional stepping, cueing, and multitasking while on the treadmill in a supervised setting. Cycling with the goal to achieve a pace of 80 to 90 repetitions per minute, which is a really hard kind of push yourself kind of pace, as well as a number of different high intensity boot camps that have different types of activities that people are doing mixed in with aerobic. I want to go back and highlight again the rate of perceived exertion for moderate and vigorous exercise. And the reason for this is just to highlight that people with Parkinson's disease frequently can have a blunted heart rate response to exercise in the absence of beta blockers. And so while it's important to know your exercise prescription values based on heart rate reserve, and we will calculate these for our patients and try to get them there, if they are achieving the rate of perceived exertion of 12 to 13 for moderate or 14 to 17 for vigorous, then we become satisfied with that, even if their heart rate isn't doing exactly what we'd like it to do. And if we have any concerns, we can refer them back to their neurologist or cardiologist if their heart rate is doing strange things during exercise. For strength training, the frequency that we recommend is 2 to 3 days a week, challenging all major muscle groups on non-consecutive days. The intensity that's recommended is 40 to 50% of a 1 repetition max for beginners and 60 to 70% of a 1 repetition max for more advanced exercisers, with the idea being to progress the number of repetitions and resistance to work muscles to fatigue. Now, we don't normally, in older adults or people with Parkinson's, actually ask them to do a 1 repetition maximum. There are a number of different formulas that you can use that will estimate what a 1 repetition max is from a 10 repetition max or from other lifting. But it works out to being, you kind of want to start your beginners to doing 10 to 15 repetitions to fatigue. And as people become more advanced, you can drop the number of repetitions to where the client is experiencing fatigue at somewhere between 6 and 10 repetitions. From a time and volume perspective, we expect that people would be starting when they're a new exerciser with 1 set of 8 to 12 or 8 to 15 repetitions and progress to 3 sets of 8 to 10 as they become more advanced, and to build to 2 to 3 hours a week of strengthening activities. That they should work all the major muscle groups of the upper and lower body using weight machines, resistance bands, or body weight. However, it is also interesting to note that there should be a focus on extensor muscles for people with Parkinson's disease because these do weaken differentially compared to the flexor muscles. There's additionally some new research coming out on resistance training with instability, which is where you might be sitting or standing on a Bosu ball or Airex foam when you are lifting weights. And with this, you can get greater strength benefits with less resistance because you have this additional instability challenge. It's interesting to note, I think, a lot of times when you think about how much aerobic exercise should I do and how much strengthening exercise should I do, and then as I discussed some of the other types of exercise, that this is where some of those boot camps and circuit training types of activities can come into play, which is a lot of times what is done in a personal training session. because you can work on both of these domains at the same time. The third domain is the balance, agility, and multitask domain. This should be done 2 to 3 days a week with a focused workout focusing on balance and agility, and with daily integration as possible for certain balance tasks. The intensity and progression are that it really should be done at an appropriate challenge based on the patient. It's very hard to judge kind of intensity of balance training, but given the setting, the appropriate challenge might be different if it's one-on-one physical therapy or personal training compared to a group exercise setting. And that the intensity and balance should progress as the patient improves and can tolerate additional challenge. The time should be 30 to 60 minutes per workout. This is based on the research studies. They are mostly kind of 30 to 60-minute exercise sessions focused on balance and agility, and it should build to 2 to 3 hours a week. Types of balance, agility, and multitask training include multidirectional stepping, weight shifting, reaching, large amplitude movements, functional agility, which may include stepping, turning, obstacles, backwards walking, and floor activities and sit to stand. Multitask training can include a primary physical balance task or walking with a motor secondary task, a cognitive secondary task, or some kind of distraction or conversation as a secondary task. It's important to note that just like the balance component is on a spectrum of intensity, the secondary task is also kind of secondary. First, you might have somebody see if they can do sustained attention on a balance task before you begin adding in a secondary task or a third task. Static and dynamic balance can also be performed on varied surfaces with different amounts of limb support and perturbations. Some examples of balance protocols include sensory motor agility program, circuit training boot camps, Tai Chi, boxing, and dance. And for flexibility, the frequency that we recommend is 2 to 3 days a week of a focused flexibility workout, but with daily flexibility being most effective. The intensity is that the individual should complete full extension, flexion, or rotation stretches to the point of slight discomfort, and they should progress as the patient can tolerate. It's a good time or volume would be 60 seconds per muscle, which could be done in a static stretch of 15 to 60 seconds with 2 to 4 repetitions of each stretch. In addition, it's important to note that dynamic stretching of 8 to 10 movements in each direction can be important, particularly before more intense aerobic or strengthening workouts. The types of stretches should be all major muscle groups, and one way to do this would be first thing in the morning when one wakes up, or before bed or after exercise, just going through and doing all the muscles. As I mentioned before, dynamic stretching prior to intense aerobic or strengthening exercise, and it can be important to include diaphragmatic breathing and meditation, or it is an option to include diaphragmatic breathing and meditation. The special considerations presented in the Parkinson's Foundation exercise guidelines are a first step at outlining certain knowledge that, when applied appropriately, are a part of the specialized knowledge and competence of an exercise professional. However, the competencies really go into more detail about how the trainer or group exercise professional might need to consider these things. So for aerobic exercise, it's important that while we might be targeting that specific exercise intensity, we do need to prioritize safety related to the client's ambulatory status, the physical activity requirement, and the use of equipment. Many individuals with Parkinson's have freezing of gait, and so the trainers need to be, or group exercise instructors need to be aware of the risk of freezing of gait. They also need to consider comorbidities, including musculoskeletal and cardiorespiratory comorbidities. So knowing if the exercise that you're doing is going to exacerbate a risk of lower extremity joint pain, heart problems, or back pain. Further, there's a risk of autonomic dysfunction in people with Parkinson's disease, which can include orthostatic hypotension, as well as the blunted heart rate response to exercise that I mentioned earlier. There's also arrhythmias that can be associated with Parkinson's or the medications that they're on. So it's important, I think, here if a exercise trainer or does not have experience with these and the patient reports that they have these, or if it's a personal trainer who can monitor heart rate, and blood pressure, it's important that the community have physical therapists and doctors that they can refer the patient back to if in case medical clearance is required for exercise or for to increase the intensity of exercise. For strength training, it's important that the trainers consider posture and body mechanics of the individual with Parkinson's disease. They should estimate the one repetition maximum, not complete the one repetition maximum, to ensure the safety of the participant. It should be progressive with high repetitions to start the exercise before increasing the intensity and strength that is being lifted. Strength training should be timed for on periods for optimal functioning. And for safety, they should consider avoiding heavy free weights and use machine-based weights or lighter dumbbells and body weight combinations. They also need to consider comorbidities for strength training, which can include the same orthopedic risks as well as other disorders that include spinal stenosis, osteoporosis, and osteopenia, which may limit some of the activities that you would have a person with Parkinson's do. For example, you may not have them challenge themselves into full flexion or full extension, and those comorbidities affect strength and flexibility. For balance, agility, and multitasking, the special considerations are to consider the variability levels related to cognitive engagement and attention as the disease progresses, to allow individuals to have upper extremity support when they need it, to consider comorbidities, for example, peripheral neuropathy or cognitive decline that can affect somebody's ability to follow complex instructions or complex movements, or to have adequate sensation in their feet, and the risk of freezing of gait and use of a gait belt for safety when needed. For flexibility, it's important that the exercise professional consider dystonia and whether a person is experiencing the typical Parkinson's related rigidity or if they're experiencing the dystonic positions or that could be tonic dystonia that's just always there or activity induced, and to have the client talk to their doctors or physical therapists if they have any concern about the type of stiffness that the patient is reporting. It's also important for them just to be aware of the general worsening of flexed posture with disease progression. So they're helping the person kind of work on extension and getting up straight as much as they can, even starting early in the disease, and that they need to consider comorbidities, including osteoporosis, pain, and dystonia.